Hello everyone. In last lecture we discussed about how to detect PDA. Today we will discuss about how to manage a PDA. So in coming 10 minutes we will see that should we close PDA or not. We have to assess the risk benefit and then we have to decide we should close or not. Second, if we have to close, then when to close. Different timings are there. First is prophylactic closure, symptomatic closure or early targeted approach. So three approaches are there for closure of PDA. Third, how to close or how to manage. So different strategies are there. First is the general or non-pharmacological management of the PDA. Second, pharmacological, then surgical ligation or device closure. Then we'll see what are the different medications are available for the PDA closure and what are the side effects, what are the indication, contraindications and what is the efficacy. Then we'll see the choice of medication depending on the efficacy, side effects and contraindication, which is the best. So these things we will discuss in coming 10 minutes. So first coming to should we close the PDA or not. So much controversy is there in this topic. So some studies says that we should close PDA early because PDA increases the risk of the IVH, pulmonary hemorrhage, NEC, BPD. But some studies says that don't close the PDA, leave it and wait for spontaneous closure. So we have to decide, we have to balance the risk and benefit of the PDA closure. So some studies say that closure of PDA decreases the risk of the IVH, decreases risk of the pulmonary hemorrhage, decrease risk of NEC, BPD or PVL. But what are the risks of the PDA closure? Because with medicines we use that increase side effect, they have side effects, they have increased risk of the acute kidney injury, platelet dysfunction, bleeding. So these side effects also are there. So we have to balance the risk and benefit of the closure of the PDA and then we have to decide. So when to close, we can see that if hemodynamic significant PDA is there and PDA is causing any problem to the baby. So if PDA causing problem to the baby means PDA is causing shock, hypotension, respiratory deterioration, respiratory support dependency, extreme preterm baby less than 28 weeks or less than 1 kg baby, and baby also inotropes, we are not able to wean from the ventilator or respiratory support. So in these conditions we can decide to close the PDA. So like this we have to assess the individualize and then we have to decide. Next coming to what is the appropriate timing of the PDA closure, when to close the PDA. Three approaches are there. First is the prophylactic closure, symptomatic closure and early targeted approach. First, prophylactic closure means we are closing the PDA before starting of the symptoms. There are no symptoms of the PDA, still we are closing the PDA prophylactically. So it reduces the risk of the severe IVH, reduces the risk of pulmonary hemorrhage and need of the surgical closure also is reduced. But it has no effect on the long-term outcome like mortality, neurodevelopment impairment, etc. So this one is not recommended nowadays because many PDAs which would have closed spontaneously, unnecessarily we are exposing the baby to the NSAIDs and they have high side effects also. That's why this one is not recommended nowadays. Second is the symptomatic closure. Means after appearing of the symptoms of the PDA, we are closing the PDA. So it has early or late, before 7 days or after 7 days. So early approach we use in extreme preterm babies, extremely low birth weight babies and babies having shock and respiratory support dependency. Late approach we can use in more mature babies, more than 28 or 30 weeker babies, relatively stable babies having mild symptoms of the PDA. So these are, we are closing after appearing of the symptoms. Third approach is the early targeted approach of the PDA closure. This is based on the echocardiographic features. So we have to do echocardiography soon after the birth and within 12 hours we have to decide that what is the size of the shunt. If shunt is large size, hemodynamic significant PDA is there according to the echocardiographic features and babies extreme preterm less than 26 week with respiratory support dependency. In these babies, we can use this approach, early targeted approach. But this approach also has no benefit on the BPD, NEC or mortality. So currently, generally we are using this symptomatic closure only. In extreme, sometimes extreme preterm babies, we can use early targeted approach also, but prophylactic approach is not recommended. Next is management of the PDA. First is the general or non-pharmacological management. So in that, we should restrict the fluid, or we should avoid the excessive fluid, excessive eye fluid. So we should restrict the fluid, because excessive eye fluid will cause increased preload and increase left ventricular dilatation, that will increase the pulmonary edema. Second, we should give adequate PEEP, or we can increase the PWP, that will increase the PVR, pulmonary vascular resistance. Because of increase in PWP, there will be increase in the pulmonary vascular resistance, that will reduce the left to right shunt. If PVR is increasing, that will reduce the left to right shunt through the duct. So duct shunting is reducing here. Next is permissive hypercapnia. Slightly higher PCO2 we can maintain through ventilator settings. That also will increase the pulmonary vascular resistance, and that will reduce the shunt through the duct. So this shunt is there. Left to right shunt will reduce because of increased pulmonary vascular resistance. Next is previously used to give furosemide or diuretics, that is not recommended, because furosemide can dilate the PDA. Furosemide can dilate the PDA and can increase the diameter of PDA, that will worsen the PDA, that will increase the left to right shunt. That's why furosemide is not recommended. Fluid restriction, increase PWP and increase of PCO2 we can use in general management. Next is pharmacological management. 3 medications are available. We will discuss in detail. Ibuprofen, Indomethacin, Paracetamol. Next is surgical ligation of PDA we can do, or device closure in cath lab we can do for PDA. Now we will discuss about the drugs and their doses, side effects, contraindications. So first is Indomethacin. So Indomethacin is IV is available. Loading dose we have to be 0.2 mg per kg. Loading over 30 minutes by infusion. Then maintenance dose 0.1 mg per kg per dose 12 hourly for 2 days. If baby is less than 2 days old, between 2 to 7 days 0.2 mg per kg per dose 12 hourly 2 days. If baby is more than 7 days, 0.25 mg per kg per dose 12 hourly 2 doses. So this is the dose of Indomethacin infusion. We have to give IV infusion over 30 minutes. Ibuprofen only oral is available in India. Loading dose 10 mg per kg only we have to give. After that, on day 2 5 mg per kg, day 3 5 mg per kg. This is the oral suspension. Paracetamol we can give oral or IV. Same dose is there. 15 mg per kg per dose 6 hourly for 3 days. So all the 3 drugs are for 3 days. So and this is the dosage. This is the IV. This oral is oral or IV. IV if we are giving, we have to give over 30 minutes infusion. Then coming to what are the adverse effects of these drugs. So Indomethacin has highest adverse effects, highest side effects of this Indomethacin. First is renal impairment, renal failure or acute kidney injury. Risk of NEC, platelet dysfunction, bleeding or perforation if we are given with steroids. Sometimes preterm babies will give steroids also. So with steroid there is high risk of perforation will be there. So Indomethacin has higher side effects. Ibuprofen also has these side effects but in lesser amount. So in safety profile is better with Ibuprofen as compared to Indomethacin. Third is Paracetamol, safety profile is even more better, and here adverse effects are hepatic dysfunction. Here renal and platelet and bleeding are less, but hepatic dysfunction is there with Paracetamol. Coming to contraindications for Indomethacin, thrombocytopenia, severe thrombocytopenia less than 50 to 60,000, bleeding, major bleeding disorder like hemorrhage, IBH or any bleeding is there, oliguria less than 1 ml per kg per hour, or acute kidneys. These are the contraindication for Indomethacin. For Ibuprofen also same contraindication. For paracetamol, hepatic dysfunction or increased SGOT-PT is the contraindication for paracetamol infusion. So this is the one course of the drug for 3 days. If PDA does not close after that one course also, we can repeat one more course. Maximum 2 courses are recommended. So here we can repeat same 3-day course. Here also same 3-day course we can repeat. Here we can prolong this for up to 7 days. If PDA doesn't close, we can prolong this paracetamol infusion or oral up to 7 days. So we'll see the comparative risk and benefit of all the medicine. First is the recent meta-analysis showed that oral ibuprofen has highest efficacy for PDA closure. It closes 70 to 80% closing rate is there for oral ibuprofen. So this one is the best according to the recent trials. If we compare between the IV indomethacin and oral ibuprofen, in this also we should prefer the oral ibuprofen because of the safety profile is better with ibuprofen. Efficacy is the similar between the IV indomethacin and ibuprofen, but because of the safety profile, we should prefer the oral ibuprofen. Then coming to the between the oral ibuprofen and paracetamol. In that also efficacy is slightly more with oral ibuprofen, but because of risk safety profile is better with the paracetamol. It has lesser side effects. So oral or IV PCM infusion also we can use. So in that efficacy wise ibuprofen better, but if we see the risk benefit of the safety profile also, then paracetamol infusion also we can use. Nowadays this one is becoming more popular because of the lesser side effects. Because recent studies have shown that PCM also is not inferior to the as compared to the ibuprofen or indomethacin. Closure rate are almost similar. Next coming to the between the IV or ibuprofen or oral ibuprofen. In that also oral ibuprofen closure rates are more with oral ibuprofen as compared to the IV. And IV formulation is not available in India also. And that's why oral is preferred. But if baby is not on feeds and any contraindication of the oral medication, that we can use IV also. Otherwise, efficacy is more with oral ibuprofen. So in short, if we want to summarize the choice of medication, we can give order of like this. First is oral ibuprofen is best as per efficacy and safety profile. Second is IV paracetamol infusion is better because of the safety profile. Then oral paracetamol. And then last is the IV indomethacin, because IV indomethacin adverse effects are very high and nowadays availability also is an issue. Now we'll see the when to go for surgical ligation of the PDA. So indication for surgical ligation, if failure of the closure even after 2 course of the pharmacological therapy. So first is the even after 2 course also we are not able to close the PDA, we can go for surgical ligation. Or there is any contraindication of the medications like NEC, bleeding disorder, AKI. If these contraindications are there, we can go directly for surgical closure also. Many studies have shown that because of surgical closure increases the risk of the BPD, ROP or neurodevelopment impairment in long term. But this may not be because of the surgical closure, because these babies went for surgical closure maybe because of the disease was more severe in that, because the PD was more hemodynamic significant, last shunt was there, that was causing problem, and baby was more ventilator dependent, prolonged ventilator support was there. Because of that, these babies had increased risk of the BPD, ROP or neurodevelopmental impairment. But studies have shown that surgical ligation reduces the risk of the mortality also. So this was our surgical ligation. One thing we'll discuss in surgical ligation, during surgical ligation, after the procedure, babies will go for the post-ligation cardiac syndrome. In that what will happen? Because of when we close the PDA after surgical ligation, there will be sudden increase in the afterload and decrease in the preload. Because now low pressure pulmonary circulation have stopped. So after ligating the PDA, there will be increase afterload and decrease preload. So here we have ligated the PDA, previously left to right shunt was there. So this was decompressing the flow. But here we have stopped this flow. So there will be left ventricle has to pump against the higher systemic vascular resistance. That's why there will be load on the left ventricle. So LV dysfunction will happen. Because of LV dysfunction, there will be pulmonary edema will happen. So there is increase of the afterload and there is decreased preload. Because of there is no shunting left to right shunt, that's why preload also has decreased. So because of increased afterload and decreased preload, hypotension will be there because stroke value will decrease, cardiac output will decrease, and LV dysfunction will be there. Because of that, hypotension will happen. So in this syndrome, there will be hypotension, there will be LV dysfunction. This happens mostly in extreme preterm babies, less than 26 weeks, less than 1 kg babies, or less than 4 weeks babies. This will happen more. How to manage this? So because of this, for LV dysfunction, we have to give inotropes, dobutamine, or sometimes we can give milrinol also. So in this inodilator will be there. In this inotrope and vasodilation, that this will reduce the systemic vascular resistance and increase the cardiac output. So dobutamine or milrinol we can give. For ventilator support, we have to give for pulmonary edema or worsening respiratory situation. Sometimes these babies can require hydrocortisone also for shock management. So this was about the surgical ligation and the complications after the surgical ligation and how to manage that. So this we have discussed about everything about the PDA management. Thank you so much.